Thank you very much, and my pleasure again to speak to you. This morning's lecture is the physiological basis of mechanical ventilation. In early 2017, New York University organized a symposium to celebrate the 60th anniversary of the Nobel Prize awarded to André Cournand and Dickinson Richards. These were the last North American practicing clinicians who received the Nobel Prize. The following lecture is a presentation I made at the symposium. Cournand and Richards made seminal observations concerning the effect of positive pressure ventilation on cardiac output. Yet the link between physiology and mechanical ventilation is better made by a concept of another Frenchman, Claude Bernard's milieu interior. Patients admitted to the ICU exemplify par excellence a disturbance in this milieu. Although respiratory failure is defined conventionally in terms of abnormal blood gases, hypoxia, hypercapnia, these are rarely the reasons for the institution of mechanical ventilation. Instead, mechanical ventilation is typically instituted because of disturbances in the framework first articulated by the Swiss physiologist Rohr and subsequently developed by Fenn, Otis, and Rahn. That is, the arrangements in respiratory mechanics leading to marked increases in work of breathing. In patients who develop acute respiratory failure, inspiratory effort increases about 4 times above the normal value, and the increase is 6-fold in some patients. In such patients, the respiratory muscles account for about 20% of total oxygen consumption, and more than 50% in some patients. The overriding objective of mechanical ventilation is to decrease the oxygen cost of breathing and so enable oxygen stores to be rerouted to the respiratory muscles to other vulnerable tissue beds. Patient work during mechanical ventilation is primarily determined by a physician's ability to align the cycling of the machine with the rhythm of the patient's respiratory centers. The rhythm of breathing, however, exhibits considerable breath-to-breath variability. In the 1950s, 60s, and even 70s, neuromuscular blockers were administered to prevent patients from bucking against cycling of the ventilator. Today, almost all ventilator modes are cycled on by a patient who triggers the pneumatic system that delivers inspiratory flow. Problems in aligning the cycling of a ventilator with a patient's own rhythm of breathing may arise at 3 points: cycling on, post-trigger inflation, and cycling off. For a given trigger sensitivity, patient respiratory motor output determines the delay between the onset of inspiratory effort and the onset of ventilator unloading. When respiratory drive is low, assistance may not begin until well into a patient's inspiratory time, thereby causing the ventilator to cycle almost completely out of phase with the patient's respiratory cycle. When patient inspiratory effort opens the demand valve, the inspiratory neurons do not suddenly switch off, and a patient may expend considerable inspiratory effort throughout the remainder of inspiration. The patient on the right exhibits a considerable delay between the onset of inspiratory effort, signaled by the vertical blue line, and the onset of flow delivery by the ventilator, signaled by the red line. The patient had to decrease esophageal pressure by more than 10 centimeters of water, overcoming the level of intrinsic PEEP in order to successfully trigger flow delivery by the ventilator. Among patients receiving a high level of ventilator assistance, a quarter to a third of patient inspiratory efforts may fail to trigger the machine. In this patient, the respiratory sensors are firing 28 times per minute, whereas the ventilator is cycling only 16 times per minute. That is, 43% of the patient's inspiratory efforts fail to trigger the machine. Some patients exhibit double triggering, where the ventilator produces 2 inflations within a single inspiratory effort made by the patient. Here, esophageal pressure falls and it remains negative for more than 1 second, whereas the duration of mechanical ventilation is only 0.6 of a second. The longer duration of neural inspiration, as compared with mechanical inflation, causes the ventilator to deliver a second breath before there's time for exhalation, producing breath stacking. In this patient, arrowheads signal 4 incidents of double triggering, with the width of the esophageal's pressure swing roughly equivalent to the duration of the patient neural inspiratory time. On the bottom tracing, patient neural inspiratory time in the double triggered breaths, which is the width of the esophageal pressure swing, is substantially longer than in the normally triggered breaths. Some might think that these triggering peculiarities are no more than arcane quirks. On the contrary, they have major significance and contribute to patient mortality when they go unrecognized. Consider mechanical ventilation in patients with ARDS, where a tidal volume of 6 ml has been shown to lower mortality. This setting is so widely accepted that it has become de rigueur in protocolized management. Protocol advocates, ungrounded in physiology, don't recognize that the low tidal volume is necessarily accompanied by shortening of mechanical inspiratory time. And once the mechanical inspiratory time becomes less than the neural inspiratory time, double triggering is inevitable. Protocol enthusiasts believe they're delivering a tidal volume of 6 ml per kilogram, but the patient is actually receiving 12 ml per kilogram, a setting proven to increase mortality. There is simply no substitute for deep understanding and clinical wisdom when taking care of patients. When patients are initially connected to a ventilator, inspiratory flow is typically set at some default value, such as 60 liters per minute. Many critically ill patients have elevated respiratory motor output, and the flow setting may not be sufficient to meet the patient's flow demands. The flow setting at 60 in this patient produced marked negative deflection in airway pressure, the triggering effort. Subsequent extensive scalloping of the pressure contour signifies that the delivered flow was insufficient to meet the patient's high demands. A flow setting of 90 resulted in a small negative deflection in airway pressure and a smooth convex pressure contour, signifying that flow satisfied patient respiratory motor output. The swings in esophageal pressure were smaller at a flow of 90, signifying greater unloading of the respiratory muscles. The next point in the respiratory cycle at which problems may arise is at the switchover between inspiration and expiration. During pressure support, the algorithm for cycling off of mechanical inflation is based on a decrease in flow to 25% of the peak value. In patients with COPD who have a prolonged time constant, more time will be required to reach this threshold. The expiratory neurons become impatient and they start to fire, causing contraction of the expiratory muscles during mechanical inflation. We became aware of this problem by looking at the contour of esophageal pressure in patients with COPD receiving pressure support. Halfway during inflation, esophageal pressure is higher than the calculated chest wall recoil pressure, shown as the dashed tracing, indicating expiratory muscle recruitment. To obtain more direct evidence, we inserted needle electrodes into the transversus abdominis. This patient with COPD receiving pressure support activated his expiratory muscles about halfway during mechanical inflation, an underappreciated form of fighting the ventilator. The most precise way to quantify a discrepancy in timing of ventilator cycling versus rhythmical activity of a patient's respiratory centers is to measure phase angle. If, for example, the major expiratory muscle, the transversus abdominis, starts to contract before completion of mechanical inflation, phase angle will have negative units. We employed a Starling resistor to induce airflow limitation in subjects and wire electrodes to obtain EMG recordings of the diaphragm and transversus abdominis. All subjects exhibited non-triggering efforts when ventilated with pressure support. Phase angle of non-triggering attempts was significantly more negative than the phase angle of attempts that successfully triggered the ventilator. This means that the length of time that the expiratory muscles had been active before cycling off of mechanical inflation was longer for the non-triggering efforts than for the triggering attempts. The longer the time that inflation continues into neural expiration, the shorter will be the time available for unopposed expiratory flow, causing elastic recoil to rise, increasing the likelihood of non-triggering. By ablating behavioral stimuli, sleep might be expected to enhance respiratory rest during mechanical inflation. But again, physiological mechanisms intervene. We undertook polysomnography in critically ill patients receiving assist control and pressure support. During pressure support, this patient had repeated central apneas. More than half the patients developed central apneas during pressure support, but no apneas during assist control. Sleep fragmentation was greater during pressure support than during assist control, 79 versus 54 events per hour. This level of sleep fragmentation is equivalent to that experienced by patients with obstructive sleep apnea, who have excessive daytime sleepiness and impaired cognition. Disturbed sleep during pressure support was related to the development of central apneas, which in turn was related to the difference between end-tidal PCO2 and the apnea threshold. The addition of dead space increased PCO2 by 4.3 millimeters of mercury and decreased central apneas from 53 to 4 per hour, and decreased the sum of arousals and awakenings from 79 to 44 per hour. So in summary, understanding of respiratory physiology is fundamental to achieving optimal synchronization of respiratory muscle groups with ventilator cycling and achieving muscle rest, which is the primary reason mechanical ventilation is instituted. Some physicians, however, do not relish a physiological, individualized approach to mechanical ventilation and prefer making everything easier guidelines. While mechanical ventilation saves many lives, it's also responsible for many deaths. Accordingly, it is critical to get patients off the ventilator at the earliest possible time. This task demands greater wisdom and cognitive skill than is required for adjusting settings on the ventilator. Randomized trials on weaning techniques reveal that physicians are inherently slow in initiating the weaning process. Weaning predictor tests consist of physiological measurements that alert a physician that a ventilated patient might be able to come off the ventilator sooner than the physician otherwise thinks. In this study, we developed a new weaning predictor test, frequency to tidal volume ratio, F over VT. When F over VT exceeds 100, rapid shallow breathing is present. An F over VT ratio of 100 performs superiorly to other weaning predictors in forecasting which patients would successfully tolerate a T-tube trial versus patients who would fail. Since our original report, the accuracy of F over VT in predicting weaning outcome has been evaluated by more than 27 groups of investigators, making it the most re-evaluated phenomenon in critical care. Some reported that F over VT was unreliable in predicting weaning outcome. But once the non-supportive data are analyzed using a Bayesian framework anchored on pretest probability, they unwittingly confirm the reliability of F over VT. If F over VT is less than 100, the physician proceeds with a weaning trial using one of two methods: intermittent unassisted breathing, as with the T-tube trial as seen here, or by gradual reduction in ventilator assistance. Weaning predictors are not done to forecast a failed weaning trial, but in order to alert a physician that a patient might tolerate a weaning trial sooner than the physician otherwise thinks, and move the weaning trial earlier in time and shorten the overall duration of mechanical ventilation. In 1994, Burchard published the first RCT of different weaning methods, showing that IMV, intermittent mandatory ventilation, was the worst method. One arm was a T-tube trial combined with assist control, but the duration of rest between each failed T-tube trial could have been as brief as 1 hour. At this time, Franco Loggi had data showing that recovery from diaphragmatic fatigue required at least 24 hours of rest. And this was the motivation behind the incorporation of a 24-hour rest arm in an RCT conducted by the Spanish Lung Failure Collaborative Group. our study revealed that T-tube trials, combined with 24 hours of rest, weaned patients 3 times faster than did IMV and 2 times faster than did pressure support. The most difficult group of patients to wean is those requiring prolonged ventilation in a long-term acute care hospital. In a randomized trial, we found that intermittent unassisted breathing using a trach collar resulted in 1.43 times faster removal of the ventilator than did pressure support. The superior outcome with unassisted breathing, T-tube or trach collar, in our 2 RCTs is best explained on the basis of physiology. During a trach collar or T-piece, the amount of respiratory work is determined solely by the patient. The ventilator cannot do any work. As such, a physician observing a patient breathe on a T-piece or a trach collar has a completely clear view of the patient's respiratory capabilities. During pressure support weaning, a clinician's ability to judge weanability is clouded because the patient is receiving ventilator assistance. And it is extremely difficult to distinguish how much work the patient is doing and how much work the ventilator is doing, even when esophageal pressure monitoring is being employed, and totally impossible to do without esophageal pressure monitoring. It may be that the ventilator is doing a moderate amount of work, or a large amount of work, or very little work. By physical examination and even by looking at the airway pressure tracings on the monitor, it is impossible to estimate how much work the patient is performing while receiving pressure support. Because of the impossibility of guesstimating work of breathing during pressure support, clinicians are more likely to accelerate the weaning process in patients who perform unexpectedly well during a T-piece or a trach collar than when a low level of pressure support is being used. Many physicians think weaning is complete when they reach a pressure support of 5 to 7, often combined with a PEEP of 5, and extubate patients from these settings. When assessing a patient's readiness for extubation, a physician needs to guesstimate patient work of breathing. Compared with work in the extubated state, breathing through the ventilator with CPAP of 0, pressure support of 0, decreases patient work by about 1%. In contrast, CPAP of 5 decreases work by 40%. Pressure support of 5 decreases work by 30 to 40%. Combined, they decrease patient work by 60 to 70%. No pharmacological agent can remotely achieve a decrease in work of breathing of this magnitude. When evaluating a patient's readiness for extubation, the thing you most want to avoid is a decrease in patient work of breathing compared to what it will be following extubation. The vast majority of patients can cope with a 40 to 60% increase in work of breathing at the point of extubation, but a fragile patient may not. To extubate a fragile patient directly from CPAP of 5 or from pressure support of 5 is to risk killing that patient. In conclusion, over the breadth of my pulmonary and critical care practice, no area demands greater understanding of physiological principles than ventilator management, and the need for physiological understanding is greatest when facilitating expeditious weaning and extubation while minimizing the risk of death. Thank you.